Well, welcome everybody. It's so wonderful as you'll just be letting people in and seeing that you're all joining us. And thank you so much for your time this afternoon. And thank you to the PCV team for putting this program together. Today, we really wanted to welcome you to the session. And I'll just let you know that we are recording the session. All your cameras are off so that you won't be showcased on the recording. But if anyone's requesting not to be on, just please recognise that the session will be recorded for those who aren't able to attend, so it can be shared. This is such important data, and I just wanted to acknowledge. I'll open firstly by acknowledging the traditional owners of the land on which we're meeting on. I'm coming to you from Bunurong lands, and we're coming right across the state of Victoria, from Yorta Yorta to Gunai Kurnai, and all the beautiful lands. They're the ones that I'm really related to and visit quite regularly. But please get your feet on some soil today and acknowledge the country and the lands that you're on. And please, I'm sure I share with you in paying respects to our elders past, present and emerging, and anyone who's joining us from who's Aboriginal or Torres Strait Islander on the call today. So this is a fantastic piece of work that we've partnered with Chris and his team from Melbourne Uni on. And I'd just like to, the Board of Palliative Care Victoria in collaboration with Violet, our wonderful CEO, really acknowledge the amazing work and contributions of the sector in putting this data together. So the goal of today is to provide you with an overview as what the data is telling us and the data that's been captured. And there will be an opportunity for questions and answers just in the chat. And you're welcome to add questions and comments while you're listening to the presentation. At the end, there will also be 3 questions that we want to put to you to gain your feedback around some key areas. There'll be a QR code on one of Violet's last slides. So rather than hear from me, let me hand over to Chris Schilling. And Chris, thank you. And I'll leave you to share with us the data and what we've got to share today.
Thanks, Kelly, and thanks all. It's a real pleasure to be here this afternoon to present this important work. We were delighted that PCV were supportive of us in completing it, and we think that data really helps to inform and should help to inform all the decisions that are made that really influence you on a day-to-day basis. And so what we've done with this work is essentially take a first step, and I'll just get a confirmation that you can see my screen. Yep, that's Kelly or Violet. Yep, can people see?
It's not in it's not in presentation mode.
Presentation mode. Oh, there we go. How's that?
Thanks. And if you can pop questions in the Q&A section rather than the chat, please. Thank you.
Perfect. Thanks, Violet. Yeah, so this work's really a first step towards a data hub for us here in Victoria, and what I'll be presenting is the initial results, the summary of those. There's a lot in the report and a lot more that we can do as well, but what we are able to do is provide really a first really in-depth look at palliative care across a number of domains, including population level need, as well as population level needs that aren't being met. We're able to look at access to palliative care in detail, quality of end-of-life care and palliative care outcome measures. And we're able to look at the workforce, at education and training, and funding and expenditure for community pal care. And as I mentioned, really our aim is that this is the first step towards an enduring, a sustainable evidence platform that we're able to look on each and every year and see, are we making progress? Are we improving like we hope we are? Now, critical to this is the underlying data, and this report utilises AHW and ABS and Peacock data, but it also utilises 3 new data sets that you in the sector won't have seen before. Firstly, we completed a bespoke community palliative care survey that looked at funding and expenditure for our community palliative care providers. Here at the Palliative Care Economics Unit, we did some health economic modelling to look at workforce and how that's changing and what that means for unmet palliative care needs. And probably the biggest addition that we've added with this report is that we've done a new data linkage with the Centre of Victorian Data Linkage here at the Department of Health, and captured information and data for every Victorian death over the last 7 years. So that's almost 300,000 deaths. And we looked at their data records for 24 months prior to death and captured their inpatient activity, their outpatient activity and emergency department presentations, as well as the cost data associated with all of that activity, and linked that with things like the National Death Register and Victorian Cancer Registry, so that we have a really in-depth understanding of that last 24 months of life for every death over the last 7 years. And so what we found in our first area or first domain was really focusing on need and unmet need. And first point that in Victoria, there's around 46,000 death seats here, and around 75% of those have some need for palliative care. So you're looking at over 34,000 Victorians who are needing palliative care each year, and this is essentially 75% of all deaths in the state. What we saw over the last 7 years is that actually the number of deaths in Victoria has grown at a rate that's more than double what the population's grown at. So this is probably what you're feeling on the ground, is that that demand for your services has been increasing really at a rapid rate. And when policy responses and what we're able to do is responding at a population level, at a per capita level, we're actually going backwards, because demand for palliative care is increasing at a faster rate. And so what we see when we look at unmet need is that actually more than half of those 34,000 people have some amount of unmet palliative care need. And that means 63 people dying a day here in Victoria with some amount of unmet palliative care needs. So while the sector does a great job when it's able to provide palliative care, what we're showing here is that actually there's a really big gap between the capacity of what we'd hope to provide, so that we can meet all the need that we're seeing in the population. When we look at what's happened to access over the last 7 years, we've seen that there has been some improvements, which is a really a good thing. So we have seen access increase from around 39% of deaths accessing some amount of palliative care in 2018 to over 44% in 2024. So that's a positive. We are seeing some growth and some expansion in access. But still, when we look at timely palliative care or early access, and defining that as receiving a first referral at least 3 months before death, less than 12% of people who died in Victoria actually received early access to palliative care. And the median time in terms of days of first referral to palliative care to death is just 16 days. And those kind of aggregate numbers, they mask some real variation by the type of disease that the patient suffered. As we'd expect, palliative care access is highest in cancer. So about 3/4 of Victorians who died of cancer received some amount of palliative care, and about 3 in 10 received early pal care. But when you move past cancer deaths to other wicked diseases like late stage kidney disease or dementia, we see that the rates of access to palliative care are really low and much lower than in cancer. Overall, in non-cancer deaths, just 6% of those deaths received early palliative care. And so when we consider how much those diseases still have a need for palliative care, we see that huge gap between need and what we're able to provide at the moment. Again, there's it's not that the sector hasn't grown, and so when we look at the workforce, we see that in 2018, looking at specialist palliative care physicians, and there are around 38 full-time equivalents working in clinical roles, and that's grown to 51 FTEs in clinical roles. over the last 7 years. So again, that's a real positive. But when we compare that to what's happening nationally and what's the benchmark, we see that we're still falling short. So Palliative Care Australia and the sector in 2018 worked to come up with a consensus target for specialist palliative care physicians per 100,000 population. And they set that minimum target at 2 FTE per 100,000 population. And currently in Victoria, we're at 0.7 clinical FTE per 100,000 population. So significantly lower than what that consensus minimum target is. And even lower than the national average, which is at about 1.1 FTE per 100,000 population. When we move to community palliative care services, and this was a result of this bespoke survey, and again, big thank you to the sector for responding and helping us get this understanding of what's happening at the community pal care level. We see that expenditure has grown faster than recurrent government funding. And really that's a key message that, the costs to you in providing palliative care have been growing rapidly, about 7% per year. But recurrent funding hasn't kept pace. And actually over the last couple of years, there's been a marked shortfall. But my last slide is moving forward. So not just looking backwards at the state of palliative care, but using some of our projection models that we've developed here at the PACE unit to look at, well, what does the future look like, given what we're doing in terms of policies on graduates training for specialist palliative care physicians and nurses. What does the future look like? Well, under business as usual, we see that palliative care needs going to grow really significantly. Again, the number of deaths are expected to grow more than double the rate of population growth. So we've got to be really mindful of that when we're talking about the need to expand services. It's not just to expand services to keep pace with population growth. We need to expand services to keep pace with increasing death rates and death numbers. And under business as usual, even with increased numbers of physicians and nurses, we expect that unmet needs going to continue to grow. So while there's been some good messages, and there definitely has been growth in the sector, what our analysis shows is actually there needs to be a bigger step change to make sure that we're reducing unmet need, not letting it grow. With my last point, I just want to move on to what we could potentially do with this data. I mentioned at the start that we're really just scratching the surface. Hopefully some of you have had the chance to walk your way through the report that we've released with Palliative Care Victoria, but it's only 25 or 30 pages long, and there's a whole range of further opportunities for research that we could do behind that. Things like looking at people's patterns of care in their last months of life and what interactions they're having with the healthcare service. For all the stats I've presented today, we can look at those for particular priority populations. It might be that you want to look at those from non-English speaking backgrounds, or for Aboriginal Indigenous peoples, or for high needs peoples. We can use that data to help break out our results for those particular priority populations. There's been some questions around aged care, and to date we haven't had the time to delve into how those results look for people living in aged care facilities. So that's another opportunity and a really important one. There's understanding the different models of palliative care. So the results that we've presented have been on aggregate, and clearly there's community palliative care and hospital-based palliative care consultancy team visits, palliative care units. We can break that up with the data that we've got. The workforce can have a deep dive into exactly where those workforce gaps are and what that's meaning for access. As health economists, where we sit, we can also investigate costs and value, because we do have the costs of all of those episodes within the data sets. Things like system integration, so where the system's working really well together and where perhaps it's doubling up. So some opportunities to look at that. And again, as I mentioned at the start, we're really hoping that this can be really a first step and something that we can update over time, because that'll provide us with those abilities to look at trends and see where we're improving and where we're not. And lastly, before I finish and throw over to Violet, I just say that we really do welcome your ideas for what would be really meaningful for you. So I'm very keen to get your feedback on what would be of most value to you. I'll leave it there and pass over to Violet, but before I do, I just wanted to thank everyone involved with this report. It's been a real privilege and pleasure to work on it. So thanks very much.
Thanks, Chris. So what I'll do now is really try and join the dots, do a bit of connecting between the data that we've got, the framework that was delivered by Minister Schilling at the National Palliative Care Week Summit, which sets our policy direction for the next 10 years, and really try and show some connectors between both of those reports and how we can think about using them going forward. And that's regardless of where your operational role is, whether it's clinical research, strategy, planning, but really to get us thinking about how can we make this data the most useful for us. And I think Chris gave us, Chris gave us some wonderful ideas in that last slide, which I really wanted to copy down, to think about things that we can do. And what I really want to do is just try and bring this together for us. So obviously we've got the two documents. Chris has taken us through the State of Palliative Care data, and with the framework, just a reminder that it's a 10-year document. It's a roadmap of how we're going to work towards delivering care in the future. And we've got the 5 priorities there as a reminder. And then you'll remember that under the priorities in the document, there's a whole series of overarching priorities and actions for us all to be thinking about what we work together with. So obviously, the first priority being providing more care at home. Chris has presented some of this data, and what I really wanted to show with this is there's many different ways within priorities to be looking at data. So the variance in costs and funding is obviously a really key one that we need to work out a way to narrow that cost and how we're going to keep delivering care in the future, and also the impact of external forces like new EBAs and the population growth, you know, and making sure that all these things are factored in so we can actually project quite a lot of variance. If we tied into this those workforce variations, so the 87% of specialist palliative care physicians that and where they're located and how are we planning services would be another way to cut and look at things. And then when we're thinking of providing care at home, if we were thinking about some of those opportunities Chris was talking about, you know, I'm thinking, well, obviously we've got caseloads between services, but I wonder what that transition time's like for people who change their decision quite close to the end of life about where they actually want to die. How often is that happening? What's that modelling look like? What's the impact on the services? What is emergency ambulance use for planned versus emergency admissions in this situation? So we can get down into the weeds and look at individual journeys, or we can lift it high and look across the system. For priority 2, when we're thinking about supporting holistic needs, and obviously there's lots of equity of access, things that we can interrogate, looking at cultural groups, disease groups, lots of demographics that we just haven't had an opportunity to explore yet, but also the many intersections. None of us are 1, 2 or 3 dimensional, so we could do some really complex understanding of our populations and our individuals, and also building that evidence base around advanced care directives and really interrogating how how, where and why, and the fact that, you know, that is at 16.7% after quite a few years of initiatives, and is that a stimulus of thinking how to do things differently? For priority 3, I think for those of you operationally in palliative care services, there's some real priority data areas in here that could be baselines, and, you know, is there opportunities for looking at benchmarking within regions, within services? We've got very clear policy direction in the framework of care for the last 100 days of life. So we need to understand that variance of the 16 days. And if we're aligning this with, in the blue box, we've got some of the key priorities and actions that are in the framework document. So that opportunity to look at consistent referral and triage, strengthening PCAS's navigation role, and bringing together all these navigation elements, what we're actually getting is some really good baseline data. So if we're working together on initiatives to make these changes, we will be able to get further data down the line to say, how are we doing against that benchmark? Have we made a difference? And we can actually look at the attribution of the actions we're putting in place. I think the workforce data speaks for itself. I've got heaps more questions about workforce data, and I know a couple have come into the Q&A already that we'll talk about after. Obviously, going back to that underservicing in the number of clinical specialist physicians, that impact of no specialist physicians outside in a regional Victoria, and it will be really interesting to populate this with all of the other workforce data around it, and how those connectors happen, and how those hub and spoke models of support happen to make sure that we're getting all the right specialist support and education in all the right places. We had some really interesting conversations developing this data when we were looking at the length of time that was provided in medical degrees spent on palliative care. So we know all sorts of weird facts now, like in medical training, there's 6 weeks spent in obstetric training and things like that. So it's quite interesting looking at the different approaches and concentration on the workforce. And then priority 5, which, you know, I think credit to the department and all of the workshops that were developed. They really did listen to everyone that attended the workshops, who talked about that real need to understand what we're doing in palliative care, where it's being delivered and how it's being delivered, and making that a key priority so that we know we're making a difference or not. And I think this work that we're doing here will really complement the approach going forward with that. And obviously we would love to get that palliative care dashboard down the line, but we're still going to need these metrics behind to keep that quality improvement as we go along. Chris has alluded to the reason why with the changing demographics. Bernard Salt said that we've got a freight train on its way to Victoria, and it's full of 85-year-olds, talking to our need to be ready for 2032. We haven't got a blueprint for caring for the population. It's amazing that and we should be celebrating the older population, but also we need to understand the best way to support and provide care in this population. Our election campaign is Tomorrow's Care Starts Today, because we really believe all of this work is going to need to develop for well over 3 election campaigns, which aligns with the 10-year framework that we've got. And when I've been talking to the politicians about supporting palliative care, regardless of their political allegiance, that we really need the whole of the House supporting the Health Minister when they go to Treasury for the funding and support to develop the palliative care framework. There's 76 Victorians a day that we could potentially be missing out on care, are the key metrics that really speak to them. So really just wanting to reinforce that this is one small step, I think someone else famous said that, on our journey towards getting to the integrated palliative care across the state that all Victorians deserve to have. And I will hand over to Kelly. I will just put this next slide on, Kelly, so that the QR code is available to everyone. And I'll just leave that on for a couple of minutes and then I'll stop sharing my screen, if that's okay with you.
No, I think it's fantastic to leave that up, Violet. So this is a QR code that I mentioned at the start, which we'd really like you to scan and just answer Violet's 3 main questions that we're keen to get your feedback on to help us prioritise, full stop, really. I just wanted to thank you, Violet, for your leadership around this data, and Chris for your amazing work of you and the team, and just acknowledge how valuable it is to have a data set that we can work from and that we can all align with, I think, and start to use these metrics, understand them for our services, and then build on that over time, which is the intention. It's always going to be challenging for us to get to make everyone happy and provide them with the data that they need. And we're trying to use sources that are readily available and also are consistently available so that we can continue to build from information that we have. Violet and Ed, is there any questions? Just as you're putting that together, I thought I'd acknowledge Ed and Heather too for the coordination of today's session, because putting these things together is never that easy, but it's always wonderful to have our backup and support in the background.
Okay, so there's a few questions popping up already. I'm smiling because I think most of them are for Chris. So
we were hoping for that.
Yeah. So sorry, Chris. So the first question is asking, is there a similar comparison for palliative care nurse practitioner numbers in Victoria compared with national averages of other states?
Haven't. Yeah, thanks, Violet. And I see that's from Mark. Mark, we haven't looked at nurse practitioners specifically, but the nurse numbers working in palliative care look reasonably good in Victoria per 100,000. So you're looking at about 13.6 FTE per 100,000, which is above the national average. So on the nurse numbers, Victoria is doing better. Interestingly, when we do project forward, however, while physician counts continue to grow per 100,000 per capita, nurses don't see that increase. So while it's probably at a better point relatively now, it doesn't seem to have that, that continued growth moving forward.
Okay. So I think the key message for that is that palliative care nurses in Victoria are above average and that we need to work on the workforce.
Exactly.
Yeah, and is that data mostly AIHW for the nurses at the moment, Chris?
Yeah, we use a data source called the Health Workforce data set, which is the official data set that then the AIHW uses to report on the workforce for all the health workforce, not just palliative care.
Okay, thank you. So whilst we're on workforce, Kathy has asked about any specialist research or data around allied health. Great question.
Yes.
And those growing trends for needs with counselling, social work, etc.
Yeah, it is a great question, and unfortunately a limitation at the moment of the data is just getting a better understanding of allied health specialists working in PAL care, and indeed, even further than that, another limitation is we don't have any good indication of generalists and the palliative care that they're providing, and that's, I think, one of the big gaps on an ongoing basis that we, as a country, kind of need to do some thinking about how we're going to measure that more broadly, because the work that we're doing shows that specialists can't, and they probably don't need to be meeting all of the need, and so we need to be making sure that that allied health, that generalists are also being measured and quantified. So we just got a better understanding as to what the trends in the numbers are looking like.
Okay, so is that a bit of a call out to our allied health colleagues then for some words of wisdom and thoughts around data collection points and opportunities that maybe haven't been explored as fully from sort of a state system level?
I think absolutely, yeah. I'd love the opportunity to meet with anyone who's interested to talk about that in more detail.
Okay, I'll add that to my wish list. Mark's asking a good question about, can we tell from death certification data if VAD's been a significant contributor to the increased connection to palliative care? My understanding when I last talked about this is that there's not a lot of connection in data between VAD and palliative care, apart from at the point that the person asks to access VAD. It's collected at that point if they've had access to palliative care, but not anywhere else along the journey, is my understanding. I don't know if either of you two have had a different experience.
No, that's my experience too, but I understand that the data has got better in the administrative systems at capturing voluntary assisted dying. And so I expect that over the next couple of years that the data will be richer, and we'll be able to do the type of study that Mark's asking for there, where we have to look back and say, well, was there some association there, and has that led to increased connection to PAL care? But in the historical data, even some of the codes didn't capture it yet. So some of that's only happened in 2025, 2026, is my understanding.
I think the overall numbers for VAD are quite low, Violet, too. So, there is so many outside of that would probably be bigger population data, but most of the services would possibly have those metrics. So we could potentially, gain those, those and triangulate it, but that we're still talking small numbers. We're hoping the changes in legislation may give more people an opportunity to access it. So we could certainly have a look at it.
Definitely. Now, Leanne's put a very specific question about page 17. I don't know if you've got the report in front of you, which is talking about figure 11 and a drop in activity, and if there were any thoughts about the explanation for that drop.
Yeah, good question. And sorry, Leanne, I'm going to have to take that one on notice. We did do some specific work with community PAL care and did see some different trends depending on different ways that you cut the data. We wanted to report contacts as a high-level number of activity, but I'll do some digging and take that one on notice and revert back to see if they're consistent trends in other metrics, for example, in patient-level numbers. I don't think it is, so I'll get back to you on that one if that's okay.
Yeah, that's great. Thank you. And John Clement, who is a great supporter and consumer helper for us here at Palliative Care Victoria, is reflecting that it seems that one of the reasons for there only being the average of the 16 days prior to death for patients being referred is a reluctance of some of the doctors to make such referrals. And I think we've definitely had quite a few conversations about that across the many opportunities that we've had to look at the data. We've also had quite a few conversations about some of the cultural groups and family groups' fear of raising the conversation as well. So I think there's a whole death literacy piece here that is much bigger than health. It's like our whole lives need this conversation, isn't it? So good, I agree, John, a good point. And we are looking at some of the triggers for referral to palliative care for just that reason.
And I'd just add, Violet, that one of the great things about the data is that we can actually look at it by different health services while it's de-identified, so we don't know specifically which service it is or which clinician was involved. We can see variation, so we can see are there, is there variation around how palliative care is referred across the state? And when you see variation, large variation, that indicates that perhaps there are, site-specific factors. Or factors that are actually modifiable, and so you can start to paint a picture that way as well.
Yeah, because I think, it is really important to reflect that this is overarching, and, none of us like to fit the overarching picture. We're all individuals with individuality and intersectionality in it. So there's always going to be a story to tell when we're doing this. So Rose is asking, she's interested in how we collected data about the receiving the palliative care and who's delivering it, and she's really thinking about the aged care workforce, who she considers us all to be generalist palliative care workers.
Yeah, great question. And so we identified if someone received palliative care through the administrative data set. So in an inpatient visit, if they're in a palliative care inpatient bed, then that was a clear one. In the outpatient, so the non-admitted data sets, we're able to identify if someone received palliative care, if they received a community pal care contact, or if they received a visit from a hospital-based palliative care consultancy team. And then in the inpatient data, we also saw that Z51.5 code, which suggests that during an inpatient stay, did they have was there a palliative approach to care listed as a secondary code? So we used all of those ways to identify if an individual received palliative care and when, and to see who was delivering it at that point. There are some limitations to that. So so Pal Care provided as a palliative approach through that Z51 might have been provided through a generalist, but any generalist outside of the hospital system isn't captured.
Yeah, and I think this is, for me, is one of the big areas of opportunities to explore and understand better. And the fact that we haven't got agreed definitions on what generalist palliative care is. And if we haven't got that, then sadly it's not recognised, it's not counted, and doesn't receive the funding and support in the way that maybe we would want to, so I think we've got some real opportunities about capability and capacity building across the system as well.
I agree. And specifically, we're able to look at a question that I know a lot in the sector have always raised, is to when an inpatient visit has that Z51 palliative approach to care, is that what's it actually providing? And so we're able to see through the linked data if a hospital-based palliative care consultant actually attended as part of that Z51, and able to see how that varies across different health services. So in some health services, it seems that happens the majority of the time, but in others, a Z51 typically isn't accompanied by a consultancy team visit. So there's some interesting nuance that we can tease out there as well.
There's so many opportunities, isn't there? Mark's on a roll today, isn't he? Who's saying that the allied health numbers are difficult, and that for everyone who may not be aware, that we've got a chief allied health advisor in the state government, and he's been having some conversations about lack of formal training of students and pathways to palliative care in the palliative care arena, and suggesting that's another connection, and hot off the press and secret to the 46 people that are in this room, so don't tell anyone else. There's been some amazing work done across allied health and nursing, and they've actually developed some thinking around that transition to special specialty pathway for workforce that are thinking of coming to palliative care, and that's going to go live on the Palliative Care Victoria website any day now, when we've got all the T's crossed and the I's dotted. So I think we've got some great innovation coming from the workforce already in this space, and we'll definitely bring the Chief Allied Health Advisor into that space as well. Rose is making a statement about GPs needing education. Did we manage to integrate or think about any of that PHN data, or is there any primary care data pulled into what we've done so far, Chris?
Not yet, Violet. Yeah, the GPs and their the provision of PAL care in primary care is again a real gap. There is a couple of MBS codes, as I'm sure the people on the call are aware, where where GPs might provide palliative care in different settings as well. But in general, we just don't have a good indication as to when a GP visit has had some palliative care provided as well. And since some surveys, national surveys were ended, that remains a critical data gap. Similarly, I have seen things previously where there've been some surveys around GP confidence and in providing palliative care, and I think that's an interesting measure that we could perhaps look at as well.
Yeah, and I think in conversations that are happening nationally with PCA, there's definitely been a lot of work going on in that engagement piece about integrating primary care into that referral journey and conversations, and especially around the end of life planning and people's choices, and the limited understanding of who's around and who to refer to for palliative care and when, which Rose has also identified that often that GPs are just so busy and got so many things on the go. How do we, make it really overt for them to understand that? So it is an interesting journey when we've got the federal and the state approaches and we're trying to connect them. Sarah Hall was just answering the question in that variance of figures and talking about how the COVID impact, and I know any of you there who on the figures and changes, anyone that was around in COVID time, especially in the community, the figures just skyrocketed, as I'm sure you've all got a bit of PTSD from, because people wanted to keep loved ones at home and not have the issue of not being able to visit or be with them when they were in hospital. And it definitely took a long time after COVID for that to tail off. And I think some of that was actually that community got real confidence in keeping their loved one at home with complex needs. It was surprising that the tail of it was quite long. I also think in palliative care, we're really good at fixing problems in a band-aid way, because we're never going to let that person down in front of us on that shift. We're always going to go the extra mile. And I think you all went the extra mile for so many weeks and months that it just carried on because you were used to going at that rate. So it will be interesting as we review this year on year to see where that tail levels out, and if where we are now is the way that we're going to be going forward, or have we still got some settling to do. So that's one of the reasons that I think the board are quite keen that we have a regular update of some of the key metrics that we agree, so we don't see this as a one and done piece of work. This is very much the start of the conversation. And yeah, John's just reminding us that University of Wollongong have got some work going on about GP involvement in palliative care. So hopefully in the QR code, for those of you who have smartphones, anyone that hasn't, you know where I am, and you can find us at Palliative Care Victoria for any words of wisdom and thoughts. But we'll be pulling together together all of your words of wisdom questions and really thinking our way through over the next few weeks and months about which direction to take things. And also we'll look at opportunities for partnerships, for research. And, you know, we really see this as stage one of a much bigger piece of work and telling the story. I'm also really supporting my colleagues in other states and Palliative Care Australia to build their own piece of data that develops alongside this, so we can do some national benchmarking as well in a really meaningful way. And Chris has certainly been engaged in a lot of those conversations, so hopefully we'll start to be able to tell the Australian story as well as the Victorian story. I think we've explored all of the questions that have come through, Kelly, so I don't know if shall I pass over to you for any final thoughts on the session?
Yeah, thanks so much, Violet. I think thank you to everyone who attended today. Hopefully it gives you some insights into the wonderful work that the team have done, and thank you to everyone across the sector who's contributed to this work. Our goal is not to duplicate or create work that's already going on in different places. So that wonderful work that, you know, Wollongong's doing at a national level and the PHN's doing around the GPs, using that data really wisely is our goal, and then using what's readily available for us and getting some benchmark data that we can use collaboratively. If you've got in-depth questions about your specific service, they're probably best held within your service, because we are looking at this as a state-based approach, and then really identifying where in the state we've got, you know, key metrics. I'd encourage, while we've got you all on the call, I'd really encourage you to look at our election asks and engage with your local members of parliament around this data. They've all been provided with this. They're wonderful metrics. We've got amazing support from the Department of Health at the moment with Mark and the team, Carrie, Janelle, you know, doing a fantastic job and are listening and engaging with us so positively. I think it's a wonderful time for palliative care. I think we're getting ourselves organised, and this is a fantastic illustration of that. So thank you, Violet, to you and the team at PCV for supporting us as our peak member body. And I hope everyone has a really lovely evening. Don't forget my opening where I said get out on country and go and you probably get wet today, actually. You probably won't get your feet, you get your feet wet rather than, you know, feel the sun on your skin. But please take care, go gently, look after yourselves, and we look forward to seeing you again soon.